Today's discussion is going to be on the respiratory system, Chapter 11. Our objectives for today are to understand the common signs, symptoms, and prognoses in pulmonary diseases, review infectious pulmonary conditions, understand the nature and prognoses of obstructive conditions, and understand the interlink between cardiac and pulmonary conditions. Structures of the lower airway include conducting airways. The initial 16 generations of airway branching in the lungs primarily serve as conduits for air movement. Transitional airways lead from conducting airway into the final respiratory zone. The final respiratory zone consists of alveoli where gas exchange occurs. Ventilation can be defined as the ability to move air in and out of the lungs by creating a pressure gradient. It involves the process of breathing, which includes inspiration, also known as inhalation, and expiration, also known as exhalation. Respiration can be defined as gas exchange process that supplies oxygen to the blood and body tissues while removing carbon dioxide. It occurs primarily in the alveoli of the lungs, where oxygen diffuses into the bloodstream and carbon dioxide diffuses out of the bloodstream. Ventilation affected by pathologies of airways, lungs, chest, wall, and diaphragm, which can impair the ability to move air in and out of the lungs effectively. Where respiration is influenced by pathologies of the lungs and cardiovascular system, which can impair the gas exchange process, affecting the supply of oxygen to tissues and removal of carbon dioxide from the bloodstream. This should be a review. Total lung capacity is the maximum volume of air contained in the lungs after a maximum inhalation. Tidal volume is the volume of air inspired or expired during normal breathing, typically at rest. Inspiratory reserve volume, IRV, is the additional volume of air that can be forcefully inhaled after a normal inhalation. Expiratory reserve volume, ERV, is the additional volume of air that can be forcefully exhaled after a normal exhalation. Residual volume, RV, is the volume of air remaining in the lungs after a maximal exhalation. It cannot be voluntarily expelled and serves to maintain lung tissue elasticity. Vital capacity, VC, is the maximum volume of air that can be forcefully expelled from the lungs after maximum inhalation. It is the sum of inspiratory reserve volume, tidal volume, and expiratory reserve volume, representing the total range of lung volume change during normal breathing. Here you can see those definitions. Hypoxemia can range from slight shortness of breath to cardiac arrest. Hypoxemia's definition is deficient oxygenation of arterial blood, which can lead to hypoxia, which is shortage of oxygen in the tissues. The etiology of hypoxemia can result from respiratory alterations such as asthma, pneumonia, chronic obstructive pulmonary disease, or circulatory impairments. Its clinical manifestations include tachypnea, rapid breathing, tachycardia, rapid heart rate, confusion, restlessness, labored breathing, and incoordination. Hypoxia's definition is a condition characterized by a shortage of oxygen in the body tissues. Hypoxemia is one of the causes of hypoxia, but other factors such as impaired circulation or decreased oxygen carrying capacity of the blood can also lead to hypoxia. Here you can see the different causes and signs and symptoms of hypoxemia. Oxygen saturation. PaO2 is partial pressure of arterial oxygen. Its definition is the oxygen pressure in arterial blood, reflecting how well oxygen moves from the lungs to the blood. Often altered by severe illnesses, the test results used to guide treatment. Components measured in arterial blood gas, ABG tests, along with other parameters such as oxygen saturation, bicarbonate, partial pressure of carbon dioxide, and pH level in red blood cells. Oxygen saturation can be assessed using SaO2, which is oxygen saturation of arterial blood, or SpO2, which is oxygen saturation detected by a pulse oximeter. SpO2 measurement is frequently performed during exercise. Caution is needed with individuals having cyanotic or cold fingers, as this may indicate peripheral blood shunting, potentially leading to inaccurate readings. General signs and symptoms of pulmonary disease include a cough. A cough is normal in healthy people. Persistent dry cough can be indicative of a tumor. A productive cough with purulent sputum can indicate infection. Dyspnea could be from increased work of breathing, respiratory muscle fatigue, increased system metabolic demand, and decreased respiratory reserve capacity. Orthopnea, shortness of breath when laying down from redistribution of body water to the lungs. Chest pain, pleural irritation in advanced diseases. Cyanosis, which is decreased oxygen saturation and circulating hemoglobin. And clubbing, which is caused by chronic interference of tissue perfusion and nutrition, often seen in cystic fibrosis, COPD, and lung cancer. Here you can see an example of cyanosis and clubbing. Altered breathing patterns. Normal breath sounds. Any change in the rate, depth, regularity, and effort is considered altered breathing patterns. Labored respiration or prolonged inspiration or expiration associated with obstructive airways. You may see adventitious breath sounds. Here is crackles, which is discontinuous, brief popping sounds. Wheezing, which is continuous musical sounds, high or low pitched. Pleural rubs, which are creaking or grating sounds that have been described as being similar to walking on fresh snow. And stridor, which is loud, high-pitched sound heard during inspiration, but may also occur throughout the respiratory cycle. Aging in the pulmonary system. Think about posture of the thorax and upper body. Assistive devices encourage forward flux posture and how that can affect the pulmonary system. Cilia are mobile, tiny finger-like projections on the surface of airway cells. Cilia line the airways and help to move mucus up and out of the lungs. Increased susceptibility to infection due to structural changes in the respiratory system can compromise its ability to defend against pathogens, leading to a higher risk of infections. Functional impairment of gas exchange. Changes in the structure of the respiratory system can hinder the efficient exchange of oxygen and carbon dioxide, affecting respiratory function. Alterations in chest wall excursion, joints, ribs, and spine. These structural changes can restrict movement and affect the ability to breathe effectively, leading to respiratory compromise. Structural changes may result in weakening of respiratory muscles, reducing their ability to generate sufficient force or breathing and maintain endurance over time. That decreased cilia efficiency. Cilia play that essential role in clearing mucus and debris from the airways. Structural alterations may impair cilia function, leading to decreased efficiency in moving harmful particles and pathogens from the respiratory tract. Increased work of breathing due to decreased lung function. Structural changes in the lungs can increase resistance to airflow, making it more difficult to move air in and out of the lungs. This increased resistance leads to higher workload for respiratory muscles, contributing to increase in work of breathing. Clinical inspection of the respiratory system includes the respiratory rate, depth, and effort of breathing, breath sounds, cyanosis, pallor or redness of skin during activity, clubbing, nicotine stains on fingers and hands, retraction of intercostal, supraclavicular, or suprasternal spaces, use of accessory muscles, nasal flaring, chest wall shape and deformity, cough, and sputum, frothy, red-tinged, green, or yellow. Monitoring cardiopulmonary status during exercise is crucial for several reasons. Impact of pulmonary impairments. Impairments in the pulmonary system can affect an individual's tolerance to increased physical activity. Monitoring allows for early detection of signs of distress or decreased exercise capacity. Healthcare providers need to clinically observe changes in cardiopulmonary status during exercise sessions. This includes monitoring vital signs such as heart rate, respiratory rate, and oxygen saturation, as well as assessing symptoms like dyspnea or chest pain. Observing changes in cardiopulmonary status enables healthcare providers to make timely modifications to the exercise program, ensuring the safety and well-being of the individual. This may include adjusting exercise intensity, duration, or mode to better suit the individual's capabilities. It's essential to communicate any observed changes or concerns regarding cardiopulmonary status to the PT overseeing the exercise program. This facilitates collaboration and ensures the exercise plan is tailored to the individual's needs and health status. Monitoring helps healthcare providers differentiate between changes associated with normal aging processes and those attributable to underlying cardiopulmonary conditions. This distinction is critical in providing appropriate care and interventions. Pneumonia is inflammation affecting the parenchyma of the lungs. It can be caused by bacterial, viral, fungal, or mycoplasmal infections, inhalation of toxic chemicals, smoke, dust, or gases, and aspiration of food, fluids, or vomitus. The pathophysiology of pneumonia: inflammation and edema lead to the accumulation of infectious debris and exudate in the acini and terminal bronchioles. Impaired gas exchange due to the filling of air spaces, leading to ventilation, perfusion, abnormalities, and dyspnea. The types of pneumonia are primary, which is independent of other diseases, or secondary, which develops during the course of another disease. Risk factors include diabetes mellitus, renal failure, dehydration, malnutrition, chronic illness, aspiration pneumonia, which is the passage of foreign materials into the trachea and lungs due to seizures, depressed central nervous system, neuromuscular disorders, or debilitating illness. The clinical presentation is pleuritic chest pain, characterized by sudden and intense, sharp stabbing or burning pain in the chest, exacerbated by deep breathing, cough, sneezing, or laughing. Pneumonia is diagnosed through a blood culture, urine test, chest x-ray, or CT scan, and it is managed through antibiotics, antifungal drugs, airway clearance techniques, and vaccination. Pulmonary tuberculosis, also known as TB, is an infectious inflammatory systemic disease primarily affecting the lungs, but may disseminate to involve lymph nodes and other organs. It's caused by infection with Mycobacterium tuberculosis, characterized by granulomas, caseous necrosis resembling cheese, and subsequent cavity formation, typically in the lungs. The types of TB are primary TB, which occurs upon initial exposure of the bacteria. In most cases, the infection remains latent and is non-communicable. Secondary TB results from reactivation of latent infection, occurring in approximately 10% of cases. It becomes communicable and active when the individual's debilitation or lowered resistance allows the bacteria to reactivate. Transmission of TB can only be transmitted through inhalation of respiratory droplets containing the bacteria. It is not transmitted through physical contact. Latent infection versus active infection. Latent infection is the harboring of Mycobacterium tuberculosis without evidence of active infection. Active infection is characterized by clinical and laboratory findings indicating active disease. Granulomas are formed by the body's immune response to encapsulate TB bacteria, causing them to become dormant. It can circulate to other parts of the body through the lymphatic system to the bloodstream. Skin test for TB. Positive tuberculin, which is a protein purified derivative, PPD skin test, indicates exposure to TB bacteria. A positive skin test will always be positive, even after treatment. Periodic TB testing is recommended. Treatment for tuberculosis. There are medications for TB, typically involving a 6 to 9 month treatment regimen. Pneumonectomy. Surgical removal of a lung sometimes is necessary in severe cases of TB. There are many symptoms associated with TB that do not appear in the early, most curable stage of the disease. Symptoms may be delayed until 1 year or more after initial exposure of TB bacteria. Symptoms suggestive of TB include a productive cough lasting more than 3 weeks, weight loss, fever, night sweats, fatigue, malaise, and anorexia. Rales or crackles may be heard in the area of the lung where there is involvement along the bronchial breath sounds if there is lung consolidation. High efficiency particulate HEP or HEPA respirator is necessary for healthcare workers. If a healthcare worker is exposed to TB, the worker has to take medications for at least 6 months to obtain clearance from a physician. Airborne precautions. Healthcare providers should wear a gown, gloves, and mask with high efficiency particulate air, HEPA filtration, when caring for patients with airborne infections like TB. Proper disposal of contaminated materials is essential to prevent the spread of infection. Screening for TB is crucial in early detection and prevention of transmission. Patients with airborne infection are often placed in a negative pressure room to prevent the spread of airborne pathogens to other areas of the facility. Treatment for TB typically involves antibiotics. The duration of treatment varies, ranging from 6 months to 1 year. Percussive techniques can be used to help with cough and secretion clearance in patients with TB. Chest wall expansion techniques may also be employed to improve lung function and ventilation. Exercise can be beneficial for patients with TB to improve overall fitness, respiratory function, and endurance. However, it should be tailored to the individual's condition and tolerance. Obstructive diseases. These include COPD, emphysema, chronic bronchitis, asthma, and cystic fibrosis. The main difficulty is during expiration where they cannot get CO2 out. COPD, chronic obstructive pulmonary disease, is an irreversible and always associated with inflammatory response to the lungs to noxious particles. Morbidity and mortality rates for COPD increase with the effects of repeated or chronic exposure to irritating gases, dust, or allergens, chronic irritation, and pollution in urban environments. Other contributing factors include chronic respiratory infections. An example is sinusitis, periodontal disease, the aging process, heredity, and genetic predisposition. COPD is characterized by chronic airflow limitation that is irreversible and progressive. Guidelines for diagnosis and management are through 2 different organizations, the Global Initiative for Chronic Obstructive Lung Disease and the World Health Organization. Etiology. Exposure to irritants, especially smoking, is the primary risk factor for the development of COPD. Other environmental factors such as air pollution and occupational exposures can also contribute to the disease. Adventitious sounds, including crackles, wheezes, and pleural rubs and stridor, can be present. Pathophysiology of COPD. There's repeated irritant exposure. So chronic exposure to irritants such as cigarette smoke, air pollution, and occupational hazards lead to lung damage. There's chronic inflammation. So irritants trigger a persistent inflammatory response in the airways and lungs. Endothelial lining damage. Chronic inflammation damages the endothelial lining of the airways and blood vessels in the lungs. Airway repair and remodeling. Continuous inflammation leads to repair processes and remodeling of the airway walls. Bronchial wall hypertrophy. Thickening of the bronchial walls occurs, contributing to airway narrowing. Decreased ciliary function and mucosal damage. Chronic irritation leads to reduced ciliary function and change to the mucus lining in the air of the airways. Excessive secretion production. Goblet cells in the airway epithelium produce excess mucus, leading to airway obstruction. Airway obstruction. Accumulation of mucus and thickening of airway walls obstruct airflow, resulting in difficulty breathing. Decreased alveolar ventilation, hypoxia, acidosis. Airway obstruction leads to decreased alveolar ventilation, resulting in inadequate oxygenation of blood, hypoxia, and respiratory acidosis due to retention of carbon dioxide. Physical examination and pulmonary function tests are key assessment tools for determining the presence and extent of COPD. Spirometry, a basic frequently performed PFT, pulmonary function test, measures lung function by assessing airflow limitation. Spirometry measures lung capacity and airflow rates, providing valuable information about lung function. Evaluates parameters such as forced expiratory volume, FEV, forced vital capacity, FVC, functional residual capacity, FRC, residual volume, RV, and FEV/FVC ratio. Spirometer measures lung capacity and airflow dynamics, assesses expired airflow rate and volume over time. Exercises focus on improving posture, facilitating respiratory muscle function, and overall conditioning. The main goal of management is to increase oxygenation and decrease carbon dioxide retention. Long-term oxygen treatment to improve oxygenation, lungs transplant for severe cases, and treatments that include bronchodilators, which are medications to reduce airway inflammation and bronchospasm, techniques to facilitate bronchial secretion clearance, prevention and treatment of respiratory infections, increasing exercise tolerance, controlling complications, avoiding airway irritants and allergens, addressing anxiety and depression, and exercise programs to improve muscle oxidative capacity are all treatments for COPD. Chronic bronchitis is characterized by inflammation and scarring of the bronchial lining, leading to obstruction of airflow and increased mucus production. Irritants such as cigarette smoke, dust inhalation, or air pollution cause mucus hypersecretion and hypertrophy of mucus-producing glands. Swollen mucous membranes and thick sputum obstruct airways, resulting in wheezing and coughing to clear the airways. Blue odor is commonly observed during sleep due to increased ventilation and increased carbon dioxide retention. Patients with chronic bronchitis may exhibit cyanosis, which is a bluish discoloration due to increased carbon dioxide levels. Barrel chest occurs when the lungs become hyperinflated with air, causing the rib cage to remain open or expanded for an extended period. The chest appears rounded and resembles the shape of a barrel. Barrel chest is commonly seen in patients with chronic obstructive pulmonary disease, COPD, including chronic bronchitis and emphysema, due to chronic air trapping and hyperinflation of the lungs. Emphysema is characterized by destruction of alveolar walls, leading to large, permanently inflated alveolar sacs. Etiology primarily linked to smoking and genetic factors. The pathogenesis includes chronic inflammation. Prolonged exposure to irritants, particularly cigarette smoke, leads to chronic inflammation of the lungs. Decreased elasticity. Chronic inflammation results in a reduction of lung elasticity. bronchial narrowing or collapse. The loss of elasticity causes bronchioles to narrow or collapse during expiration. Loss of recoil. Reduced recoil leads to air trapping in the lungs during expiration, contributing to hyperinflation and enlarged air spaces. Emphysema leads to dyspnea at rest due to the inability to expel air efficiently from the lungs. As the disease progresses, patients may develop dyspnea even at rest. Pink puffers have a reddish complexion and appear to be puffing due to inefficiency of oxygenating blood, compensating through ventilation, resulting in normal arterial blood gas levels. Often present with shortness of breath and pursed lip breathing. The term pink puffer refers to individuals with severe emphysema who exhibit these characteristics. Individuals with emphysema have a higher rate of anxiety compared to the general population. Anxiety is often associated with dyspnea or the fear of experiencing dyspnea. Again, barrel chest refers to rounded or puffed appearance of the chest, resembling the shape of a barrel, commonly observed in individuals with advanced emphysema due to chronic air trapping and hyperinflation of the lungs. PTA implications. Proximal upper extremity limb strength may be weaker compared to distal upper extremity limb strength due to reduced respiratory muscle function and altered breathing patterns. Structural alterations in the diaphragm can affect its function, leading to decreased respiratory efficiency. Optimal exercise duration. A regimen of 45 minutes, 5 days a week, or 6 weeks, for 6 weeks, is more beneficial for individuals with emphysema. This duration and frequency allows for sufficient exercise intensity and duration to improve respiratory function and overall physical fitness. Changes in breath sounds. Loss of interstitial elasticity in the lungs and the presence of air pockets due to emphysema can alter breath sounds. Air pockets act as poor conductors of sound, impairing the transmission of breath sounds and voices during auscultation. Asthma is characterized by reversible hyperirritability of the bronchial tree, leading to airway narrowing and bronchoconstriction. If left unmanaged, asthma can potentially lead to irreversible changes and contribute to chronic obstructive pulmonary disease. The exact cause of asthma is unknown, but it is believed to be linked to genetic factors. Types of asthma. Extrinsic asthma is triggered by allergens such as pollen, pet dander, and dust mites. Intrinsic asthma is triggered by non-allergen factors, including respiratory infections or reactions to medications. The pathogenesis. Exposure to irritants leads to inflammation in the airways. This inflammation causes bronchospasm and airway tissue edema. Excess mucus production further contributes to airway narrowing, leading to the characteristic symptoms of asthma. Clinical manifestations include dyspnea, wheezing, non-productive coughing, prolonged expiration, tachycardia and tachypnea, dyspnea, pale and moist perspiration. That was the sound of wheezing. Status asthmaticus is not responsive to basic medical therapies. It's considered a medical emergency due to severe hypoxemia, low oxygen levels, and hypercarbia, high carbon dioxide levels. Can lead to respiratory acidosis, a condition where the blood becomes too acidic due to inadequate removal of carbon dioxide in the lungs. Asthma is diagnosed through pulmonary function tests, which assess lung function and airflow, pulse oximetry, measuring oxygen saturation in the blood. Methacholine challenge test helps diagnose airway hyperresponsiveness. Arterial blood gas, ABG analysis, evaluates blood oxygen and carbon dioxide levels. Skin tests for allergic reactions identify specific allergen triggering asthma symptoms. Management involves avoidance of triggers, so identifying and avoiding environmental triggers that exacerbate asthma symptoms. Bronchodilators, which are medications that help relax and open the airways during an asthma attack. Anti-inflammatory agents, which reduce airway inflammation and prevent asthma exacerbations. Corticosteroids, which dampen the immune system, the immune response, and reduce inflammation, but may be associated with decreased bone mineral density, increasing the risk of fractures, especially in postmenopausal women. An acute asthma attack that cannot be altered with routine care is called status asthmaticus. Again, this is a medical emergency requiring more vigorous pharmacologic and support measures. Woe is the child who tastes salty from a kiss on the brow, for he is cursed and soon must die. This is in reference to cystic fibrosis. Cystic fibrosis is a genetic inheritance. It is genetically inherited disease caused by mutations in the CFTR gene, which leads to dysfunction of the cystic fibrosis transmembrane conductance regulator protein. This protein is involved in the transport of chloride ions across cell membranes, and its dysfunction results in thickening of secretions in various exocrine glands. Cystic fibrosis is the most common inherited genetic disease in the Caucasian population. As of 2015, the median age of death for individuals with cystic fibrosis was 29.1 years. Cystic fibrosis can manifest with both obstructive and restrictive lung disease. Obstruction occurs due to thickened secretions blocking airways, while restriction may result from lung tissue damage and scarring. Cystic fibrosis is primarily caused by abnormalities in chromosome 7 replication, leading to mutations in the CFTR gene. Dysfunction of the CFTR protein leads to impaired chloride ion transport across the cell membranes. This results in the production of thick, sticky mucus in various organs, including the lungs, pancreas, liver, intestines, and reproductive system. In the lungs, the thickened mucus obstructs the airway, leading to recurrent infections, inflammation, and eventually lung damage. In the pancreas, the thick mucus blocks the ducts, impairing the release of digestive enzymes and leading to malabsorption and nutritional deficiencies. Cystic fibrosis can also affect the liver, intestines, and reproductive organs, causing a range of complications in these systems. Clinical manifestations of cystic fibrosis vary depending on which system we're referring to. Chronic inflammation in the lungs leads to permanent damage. Symptoms include chronic cough, purulent sputum production, and difficulty with expectoration due to increased viscosity of mucus. This thick mucus becomes a breeding ground for bacteria, leading to recurrent infections. Decreased oxygen, O2, and carbon dioxide, CO2 exchange results in cyanosis, a bluish discoloration of the skin, hypercapnia, elevated CO2 levels in the blood, and acidosis, acidic pH of the blood. Cystic fibrosis affects the pancreas, leading to pancreatic enzyme insufficiency. This results in malabsorption of nutrients, greasy stools, and nutritional deficiencies. Additionally, cystic fibrosis-related glucose intolerance can lead to the development of diabetes mellitus. While much remains unknown about the pathogenesis of CF, it is believed that dysfunction of the cystic fibrosis transmembrane conductance regulator CFTR protein results in impermeability of epithelial cells to chloride ions. This leads to several key features: dehydration and increased viscosity of mucus gland secretion, particularly in the lungs, pancreas, intestines, and sweat glands. Elevated sweat electrolytes, notably sodium chloride, hence the quote at the beginning, and mechanical obstruction caused by thick, viscous mucus contributing to clinical manifestations of CF in multiple organ systems. Diagnosis of CF is through genotyping, which is genetic testing to identify mutations in the CFTR gene responsible for CF. Elevated levels of chloride in sweat measured through sweat tests are indicative of CF. This is a key diagnostic test for CF. Assess lung function, including measures of airflow and lung volumes to elevate respiratory status and monitor disease progression through pulmonary function tests. Imaging studies such as X-rays may reveal characteristic changes in the lungs associated with CF, including bronchiectasis and pulmonary infiltrates. Arterial blood gas, ABG analysis. Blood gas analysis helps assess respiratory function, including oxygen and carbon dioxide levels, as well as acid-base balances. Management of cystic fibrosis is a multidisciplinary approach. CF care involves a team of healthcare professionals, including pulmonologists, gastroenterologists, nutritionalists, physical therapists, or PTAs, and social workers to address the complex needs of patients. Treatment includes antibiotic to manage respiratory infections, anti-inflammatory medications to reduce airway inflammation, and supplementation with vitamins and digestive enzymes to address nutritional deficiencies and pancreatic insufficiency. Emerging treatments focus on gene therapy to correct the underlying genetic defect responsible for CF. Lung transplantation may be considered in cases of advanced lung disease, while liver transplantation may be necessary for CF-related liver complications. Physical therapy plays a crucial role in CF management, including airway clearance techniques to help mobilize and remove thick mucus from the lungs, as well as exercise to promote lung function and overall physical fitness. Airway clearance techniques include chest PT, postural drainage, autogenic drainage, which means self-drainage and uses different speeds of breathing to move mucus, positive expiratory device, which maintains pressure in the lungs, allowing airways open, and flutter device, pulsing air back into the lungs through a vibrating ball. Chest PT includes manual techniques such as percussion and vibration applied to the chest wall to help loosen and mobilize secretions, facilitating their removal through coughing and suctioning. Postural drainage is positioning the body to allow gravity to assist in draining secretions from specific lung segments into larger airways for expiratory or removal. Autogenic drainage is controlled breathing techniques that vary airflow to different lung regions, promoting the clearance of mucus from the airways. Positive expiratory device assists the airway clearance by providing resistance during exhalation, helping to keep the airways open and facilitating the mobilization of secretions. Flutter devices are a handheld device that generates oscillations in airflow, creating vibrations in the airways to help mobilize thin mucus, making it easier to clear through coughing. Optimal nutrition is essential for individuals with CF to maintain adequate growth, weight, and overall health. A high calorie, high protein diet is often recommended to meet increased energy needs and address malabsorption issues commonly associated with CF. Pancreatic enzyme therapy, PERT, P-E-R-T, is used to aid in the digestion and absorption of nutrients, particularly fats and fat-soluble vitamins. Regular physical activity is important for maintaining lung function, cardiovascular health, and overall fitness of individuals with CF. Exercise to help improve airway clearance, strengthen respiratory muscles, and enhance endurance and quality of life. Empowering individuals with CF to participate in their own care and management is crucial. Providing education and support to develop self-management skills, adhere to treatment regimens, and make informed lifestyle choices can help promote independence and autonomy. Now we're going to discuss restrictive lung diseases. Extrapulmonary causes of restrictive lung disorders include spinal cord injury, ALS, which is amyotrophic lateral sclerosis, myasthenia gravis, Guillain-Barré syndrome or GBS, muscular dystrophy, MD, poliomyelitis, post-surgical conditions, and musculoskeletal disorders. Clinical features of restrictive lung disease or disorders include rapid shallow respiratory pattern, chronic tachypnea or fast breathing, decreased total lung capacity on pulmonary function tests, exertional dyspnea progressing to dyspnea at rest, respiratory muscle fatigue leading to an inadequate alveolar ventilation, hypoxemia, especially in late stages. Examples of restrictive lung disorders include pulmonary fibrosis, cystic sclerosis, lung disease, and chest wall trauma or lung injury. Some key points: restrictive lung disorders reduce lung volume and compliance, leading to a rapid, shallow breathing pattern. Pulmonary function tests typically show a decrease in total lung capacity. Dyspnea may progress from exertion to rest due to loss of inspiratory reserve. Respiratory muscle fatigue can result in inadequate ventilation and carbon dioxide retention. Hypoxemia is common, particularly in advanced stages of the disease. Atelectasis, also known as a collapse of normally expanded section of the lung at any structural level. Etiology: bronchial obstruction, interference with normal lung expansion, oversedation, immobility, coma, and neuromuscular disease. Pathogenesis includes alveoli becomes airless, the alveolar shriveling, and interruption in diffusion and perfusion. Clinical manifestations include dyspnea, tachypnea, cyanosis, increased temperature, decreased blood pressure, substernal retraction, decreased breath sounds on affected side. It is diagnosed through chest x-ray, usually shows trachea, heart, and deviated mediastinum towards the affected area. Management includes a bronchoscopy or suctioning to remove the cause. PTA implications include post-operative positioning changes, breathing or airway clearance strategies, and early ambulation. Key points include atelectasis involves the collapse of alveoli or lung segments due to various causes such as bronchial obstruction or immobility. Clinical manifestations include dyspnea, tachypnea, and decreased breath sounds on the affected side. Management involves addressing the underlying cause, often through a bronchoscopy or suctioning. Physical therapy interventions may include postoperative positioning, breathing techniques, and early ambulation to prevent or manage atelectasis. Atelectasis is common after thoracic or high abdominal surgery and can worsen with narcotic use. Pulmonary edema, excessive fluid in the lungs that leaks into alveolar spaces and interstitial tissue, impairing gas exchange. Etiology, cardiac conditions, left ventricular failure, acute hypertension, and mitral valve disease. Non-cardiac conditions include kidney or liver disorders, IV narcotics, increased intracerebral pressure, brain injury, high altitude, diving, sepsis, medications, inhalation of smoke or toxins, blood transfusion reactions, shock, disseminated intravascular coagulation. Risk factors include hyperaldosteronism, Cushing syndrome, use of glucocorticoids, hypotonic fluid irrigation of nasogastric tubes. Pathophysiology includes excessive fluid accumulation in alveolar spaces and interstitial tissue, decreased space for gas exchange. The clinical manifestations include dyspnea, orthopnea, tachypnea, cough with frothy sputum, pink frothy sputum, cyanosis, crackles or wheezing on auscultation. It is diagnosed through chest x-ray or echocardiogram, also blood tests to check for BNP, electrolytes, and renal function. Treatment includes oxygen therapy, diuretics, fluid restriction, treatment of underlying cause, and mechanical ventilation in severe cases. Prevention includes lowering salt intake, managing underlying cardiac or renal conditions, and avoiding known triggers. Adventitious breath sounds are abnormal lung sounds heard in the chest, typically with a stethoscope. They can provide clues that help diagnose pulmonary or heart diseases. Some adventitious breath sounds can be heard without the help of a stethoscope. Clinical manifestations of pulmonary edema include cold-like symptoms. Patients may initially experience symptoms resembling a common cold. Persistent cough, a cough that persists and may progress to producing pink frothy sputum. Dyspnea and orthopnea, shortness of breath and difficulty breathing, particularly when laying flat. Sweating or diaphoresis, excessive sweating often associated with the body's attempt to compensate for decreased cardiac output. Crackles or rales, abnormal lung sounds heard on auscultation, indicating fluid accumulation in the lungs. There is no specific diagnostic test for pulmonary edema. Diagnosis is based on clinical presentation and symptoms. Management includes enhancing gas exchange, oxygen therapy to improve oxygenation, decreasing fluid overload with the use of diuretics to reduce fluid volume in the body, and medications to stabilize heart rate and rhythm. PTA implications include positioning in a high Fowler's position, which is sitting upright, is preferred to help alleviate symptoms and improve lung expansion. Close monitoring of respiratory rate, pattern, use of accessory muscles, adventitious sounds such as crackles, and oxygen saturation to assess respiratory function. Peripheral edema, which is swelling in the extremities, may indicate fluid overload and worsening heart failure, which can exacerbate pulmonary edema. Therefore, it is important to monitor for peripheral edema as part of overall assessment and management. Acute respiratory distress syndrome, ARDS. Acute respiratory failure following a systemic or pulmonary insult, often associated with molten organ dysfunction syndrome, or MODS. The etiology is lung injury or trauma such as pneumonia, aspiration, sepsis, or trauma. The pathogenesis includes lung injury, initial insult to the lung causing damage to capillary and alveolar cells, decrease in surfactant production leading to increased surface tension and alveolar collapse, also known as atelectasis, leakage of fluid into the alveoli resulting in pulmonary edema, alveolar collapse and fluid-filled alveolar impaired gas exchange, reduce oxygenation, hypoxia, and increase carbon dioxide levels, hypercapnia, due to impaired gas exchange. Clinical manifestations include tachypnea, rapid breathing rate, shallow rapid breathing, difficulty breathing, dyspnea, restlessness, agitation due to hypoxia, tachycardia or bradycardia, rapid or slow heart rate, depending on compensatory mechanisms and underlying causes. Buildup of carbon dioxide in the blood leading to respiratory acidosis due to impaired gas exchange. It is diagnosed through a process of diagnostic elimination. ARDS diagnosis is often made through a process of eliminating other potential causes of respiratory distress, such as pneumonia, sepsis, and other pulmonary conditions. Clinical presentation, imaging studies, and laboratory tests are used to rule out alternative diagnoses. Management includes treatment of underlying cause. It is crucial to identify and address the underlying cause of ARDS, which may include sepsis, bacterial pneumonia, trauma, or aspiration. Timely treatment of underlying condition is essential for optimal management. Supportive respiratory therapy care focuses on maintaining adequate oxygen levels and ventilation while the underlying cause is addressed. This may involve the use of mechanical ventilation, a CPAP, or supplemental oxygen to ensure sufficient oxygenation. Sedatives may be administered to reduce anxiety and restlessness in patients with ARDS, especially those receiving mechanical ventilation. Sedation helps promote patient comfort and cooperation with treatment. PTA implications include assessment of respiratory status and vital signs. The PTA should closely monitor the patient's respiratory status, including respiratory rate, oxygen saturation, and breath sounds. Any signs of respiratory distress or deterioration should be promptly reported to a healthcare team. Prone positioning can be beneficial for improving oxygenation in patients with ARDS. The PTA should assist with positioning the patient in the prone position as appropriate and monitor the patient's response to the intervention. A CPAP is continuous positive airway pressure. CPAP is a form of non-invasive ventilation that delivers a continuous positive pressure to the airways through the respiratory cycle. It is used to treat conditions such as obstructive sleep apnea and respiratory distress. It helps keep the airways open, prevents collapse, and improves oxygenation by providing a constant pressure during both inhalation and exhalation. It's administered via a CPAP machine with a mask worn over the nose and mouth during sleep. Prone positioning involves placing the patient on their abdomen, which can help improve oxygenation and lung function in individuals with conditions such as ARDS. To decrease pulmonary dead space, improve lung alterations, and redistribute pulmonary fluid. It takes the weight off the posterior lung regions, promotes perfusion in the anterior aspects of the lungs, improves oxygenation, expands atelectatic alveoli, and increases functional residual lung capacity. The patient is turned onto their abdomen, ideally in a full prone position, supported by pillows, to protect the airway and allow for suctioning if necessary. Tolerance may build up with repeated use of the position, and the duration and prone positioning may vary based on the individual's response and clinical condition. Lung cancer is a malignant tumor that arises from the respiratory tract epithelium and is the leading cause of cancer-related deaths in the United States. The most prevalent subtype of lung cancer is adenocarcinoma. The etiology is cigarette smoking is the primary risk factor for the development of lung cancer, accounting for the majority of cases. Exposure to tobacco smoke in an environment also increases the risk of lung cancer, which is secondhand smoke. Inhalation of carcinogenics such as asbestos, uranium, radon, and air pollution in certain work environments contributes to the development of lung cancer. Dietary factors may play a role in lung cancer risk, although the precise mechanisms are not fully understood. Genetic predisposition and inherited mutations in oncogenes, tumor suppressor genes, and detoxifying genes can increase susceptibility of lung cancer. Carcinogen exposure. Inhalation of carcinogens from tobacco smoke, occupational hazards, or environmental pollutants lead to DNA damage within the respiratory epithelial cells. Carcinogen-induced DNA mutations affect key genes involved in cell growth regulation, including oncogenes, tumor suppressor genes, and detoxifying genes. Accumulation of genetic alterations drives the progression of normal cells to malignant cells, resulting in uncontrolled cell proliferation and tumor formation characteristic of lung cancer. Here you can see some of the various different types of lung cancer. Clinical manifestations in early stages are same as those who are chronic smokers, so people do not seek medical attention immediately. It can metastasize rapidly due to good blood supply, and the curability remains poor due to late detection. The clinical presentation of lung cancer varies depending on the location and the extent of the tumor. Common symptoms include anorexia, fatigue, weakness, unexplained weight loss, wheezing, coughing up blood, persistent chest pain that may be poorly defined, orthopenia, dysphagia, symptoms of vascular and nerve irritation due to pressure from the tumor. It is diagnosed with a chest X-ray, which is the initial screening tool to detect abnormalities in the lungs. CT scans, also known as computed tomography scans, provide detailed images of lungs and assess the size, location, and spread of the tumor. Other diagnostic tests may include bronchoscopy, biopsy, and PET scans. Management. Treatment options for lung cancer depend on the stage and the type of cancer as well as the patient's overall health. Radiation therapy uses high energy rays to kill cancer cells and shrink tumors. Chemotherapy uses drugs to kill cancer cells or prevent their growth and spread. Surgery may involve removal of the tumor, a wedge resection, lobectomy, or pneumonectomy, or the entire lung, depending on the extent of the disease. Targeted therapy and immunotherapy are newer treatment approaches that target specific molecular abnormalities in cancer cells or boost the body's immune system to fight cancer. PTA implications: educate the patient about the nature of their condition, including the potential for metastatic spread to the long bones and thoracic spine. Provide information about common symptoms such as progressive back pain and nerve compression symptoms, emphasizing the importance of timely reporting. Discuss the potential side effects of chemotherapy and radiation therapy and strategies to manage them. Design a tailored exercise program to improve strength and endurance, taking into account the patient's current fitness level and treatment plan. Focus on exercises that target the affected areas while ensuring proper form and technique to prevent injury. Regularly assess the patient for signs of metastatic spread, particularly to the long bones and thoracic spine. Monitor for symptoms such as progressive back pain and nerve compression symptoms, and promptly report any changes. If the patient fails to progress or experiences worsening symptoms, consider reevaluating their condition and modifying the treatment plan as necessary by the physical therapist. Adjust the exercise program or interventions based on the patient's response and any new developments in their condition. Energy conservation. Educate the patient on energy conservation techniques to manage fatigue and optimize daily activities. Encourage pacing activities, prioritizing tasks, and taking frequent rest breaks as needed. Regularly monitor vital signs and laboratory values to assess the patient's overall health and response to treatment, and communicate any significant changes to the healthcare team for further evaluation and management. Core pulmonary heart disease, is right ventricular enlargement secondary to pulmonary hypertension. Highest prevalence in male, often due to smoking, but also increasing in female population. Frequent cause of death among COPD patients. It is associated with pulmonary disease, left heart failure, and emboli. Pulmonary artery hypertension leads to increased pulmonary vessel pressure, resulting in right ventricular overload and hypertrophy. It presents as progressive shortness of breath, especially with exertion, decreased cardiac output with exercise, but normal at rest, wheezing, weakness, increased fatigability, heightened anxiety, and peripheral swelling. It is diagnosed through electrocardiogram, radiologic tests such as chest x-ray, physical examination, and pulmonary function test. It is managed through a reduction in right ventricular overload, provide supplemental oxygen as needed, implement sodium and fluid restrictions, and administer diuretics to manage fluid overload. PTA implications include infection prevention in COPD and core pulmonale, hand hygiene and precautions, early detection of infections, monitoring for respiratory failure. Also, education on diaphragmatic and pursed lip breathing techniques. Pneumothorax. Pneumothorax refers to the presence of air or gas in the pleural space surrounding the lungs. This condition can occur spontaneously or as a result of trauma or medical procedures. Risk factors include smoking, which is a common risk factor for developing a pneumothorax. Certain medical procedures, known as laterogenic causes, can inadvertently lead to a pneumothorax. The pathogenesis is the presence of air in the pleural cavity disrupts the pressure equilibrium, leading to lung collapse. This collapse results in symptoms such as shortness of breath and a shift in the mediastinum. Clinical manifestations include symptoms such as dyspnea, shortness of breath, chest pain, decreased blood pressure, weak and rapid pulse, decreased chest mobility, and reduced breath sounds on the affected side. It's typically diagnosed and confirmed through chest x-rays taken during inspiration, blood gas analysis, and assessment of symptoms. Treatment depends on the extent and severity of the pneumothorax. Supplemental oxygen may be provided to alleviate symptoms. Traumatic pneumothorax often requires the insertion of a chest tube to remove that air from the pleural space and restore normal lung function. There's often a shift towards the unaffected side. In the case of a pneumothorax, there may be a noticeable shift of the mediastinum and trachea towards the unaffected side due to the loss of negative intrathoracic pressure on the affected side. Tension pneumothorax is a severe complication characterized by the accumulation of air or gas in the pleural cavity under pressure. This can lead to severe hypoxemia, dyspnea, and hypotension. For small pneumothoraxes, rest and supplemental oxygen may be sufficient. However, with tension pneumothorax requires immediate intervention, which may include needle decompression or chest tube insertion to evacuate the accumulated air and restore normal lung function. In the case of a trauma, such as a motor vehicle accident, assault, or traumatic falls, the presence of undiagnosed, non-displaced rib fractures or rib fragments must be considered when getting a person up for the first time. The patient's movements and the actions of parasternal intercostal muscles can displace a rib, causing puncture of the lung or penetrating aortic injury. It is important to monitor vital signs regularly, including blood pressure, heart rate, respiratory rate, and oxygen saturation, to assess the patient's condition and response to treatment. Keep an eye on the sudden changes in the patient's condition, such as altered breathing patterns, sudden onset of shoulder or chest pain, drop in blood pressure accompanied by a weak and fast pulse, pallor, dyspnea, or increased anxiety. Act promptly if any of the signs of complications occur. Be cautious when mobilizing trauma patients, especially those with suspected confirmed pneumothorax. Early mobilization should be performed with care to prevent exacerbating the condition or causing further complications.